Good afternoon, Peter Goertz. I'm a psychiatrist. Drug interactions in psychiatry, just like interactions between people, interactions between drugs can be problematic. I once was working on an inpatient psychiatric ward and a lady came in toxic from lithium, so very high lithium level. And what had happened was that she'd taken ibuprofen, Motrin, in large amounts regularly, and that had caused the lithium level to be toxic, so very high with severe symptoms and signs. So lithium is a medicine one has to be very careful with regarding drug interactions. The lithium half-life is about 24 hours. So you want to be careful. If you want to get a valid half-life, a steady state half-life, you have to wait about 5 days on a given lithium dose in order to get a good trough level that's valid. Another issue that can happen quite frequently is thiazides can increase lithium. And in today's talk, it's a brief talk, I'm just going to focus on somewhat practical things that can come up in everyday psychiatric practice. So thiazides can significantly increase lithium levels also. So that's a combination to try to avoid. Depakote can increase lamictal levels, and that can make Stevens-Johnson syndrome, a side effect of lamictal, more likely. So one has to be very careful if you want to prescribe Depakote and lamictal together. Prozac is a medicine that is metabolized by the cytochrome P450 2D6 enzyme, and it can markedly elevate other medications that are metabolized by that same enzyme, P450 2D6, cytochrome P450 2D6. And once I was treating a gentleman in an outpatient clinic, and he'd been on an inpatient psychiatric ward. And what had happened was he'd been on Prozac, and then Wellbutrin was added as far as I remember. And then the dose of Prozac was increased from 20 to 40 milligrams. I think he was on either 150 milligrams or 300 milligrams of Wellbutrin XL. And during the time I was seeing him in the clinic, I mean, not at the visit, but he actually had a seizure at one point and had to go to the emergency room. So that is definitely something to watch out for, interactions between Prozac and other drugs that are metabolized by P450 2D6. And it really is different from patient to patient because many patients are on the combination of Prozac and Wellbutrin, but this particular patient unfortunately had a seizure. And again, one has to be careful, but I have patients on Prozac and Wellbutrin who've been on those two medicines together for years and have not had a seizure. Prozac is also significant because it has a long half-life. Prozac's half-life is 3 days. The major metabolite, norfloxetine's half-life is 7 days. So Prozac is almost like a depot medicine. It stays in your system for a long time. So any drug interactions, even if you stop the Prozac, can continue potentially for quite some time. Tegretol is also, which is carbamazepine, Tegretol is also significant medicine as far as drug interactions. It can induce liver enzymes. It can induce actually the liver enzymes that metabolize Tegretol. I think it's 3A4, cytochrome P450 3A4, and maybe another enzyme also. I think it induces more than one enzyme in the liver, and therefore it can induce its own metabolism. So the half-life of Tegretol is initially about 30 hours if you just start prescribing it. But then down the road, the half-life, let's say a month after you've started it, the half-life of Tegretol carbamazepine is quite a bit shorter, so 15 hours. So after about a month on Tegretol, the half-life is down from 30 to 15 hours. So that is also a significant change due to the induction of enzymes in the liver. So Tegretol basically revs up enzymes in the liver, causes more metabolism of itself and various other medications. Trileptal is similar. So Tegretol is carbamazepine, Trileptal is oxcarbazepine. Trileptal is similar chemically to Tegretol. However, it causes less enzyme induction and unfortunately more hyponatremia. So Tegretol is also known for causing low sodium, and Trileptal is even more likely to cause low sodium, low serum sodium. So you have to be very careful if you want to combine. I mean, it's done, but you have to be careful. You have to watch out for hyponatremia if you combine, especially if you combine Trileptal or Tegretol with other medicines like SSRIs that can also decrease serum sodium. I recently, this past week, saw a patient who was on risperidone and cogentin together, and the cogentin was given to avoid extrapyramidal symptoms due to risperidone. However, one has to be mindful of half-lives of medications because the risperidone half-life is about 24 hours, whereas the cogentin benztropine half-life is only about 12 hours. So this patient was taking both only at bedtime. So she was taking risperidone at bedtime and cogentin at bedtime. So theoretically, after 12 hours, the cogentin half-life is, the cogentin serum level is only about half of what it was previously, whereas the risperidone half-life is about 24 hours. So the risperidone level relative to the cogentin level was quite high after about 12 hours. So theoretically, she could have gotten extrapyramidal symptoms after about 12 hours, or more likely after about 12 hours after the last cogentin dose. So in theory, again, it would be more wise to prescribe cogentin twice a day. Risperidone, like I said, the half-life is about 24 hours, so usually you can get away with prescribing it once a day. Abilify has quite a long half-life, about 3 days, 72 hours, so it's also similar to Prozac in that respect. It's also somewhat like a depot medicine, so it sticks around for quite some time. So any potential adverse effects like akathisia, for instance, restlessness from Abilify can stick around for quite some time, or Abilify sometimes can cause insomnia. So even if you give it in the morning, you can have insomnia because of the long half-life. Thank you.